Hello and welcome to Matters That Matter. I'm Dr. Deepam Dash and today we'll be reviewing part 1 of neurology. Stay tuned and let's start. We'll cover the format of a case for OSCE and these illnesses. At the end, I will be giving you some tips. In this video, I won't be reading off from the slides, hence if you wish, you may pause and take a note of the information. Whenever you're in an OSCE, know how it will be conducted, how much time you have, what are the information that will be available outside or inside the cubicle, and what is expected from you. I sat for a PLAB exam and in that, these details were usually given. Since the areas of assessment involve interpersonal skill, data gathering, and management, my focus in the upcoming videos will be about that. I will also be giving you some notes and tips about the topic to refresh our memories. In the video to come, I will also speak about ICE. If you already know what that is, please drop it in the comment section. Usually ICE helps in improving your IPS and also avoids making the patient feel at a loss or not listened to. As a doctor, one of the main skills that will be expected from you is to listen attentively and remember. Let us now have a look at temporal arteritis, which is also known as giant cell arteritis. It is known as arteritis because it is an autoimmune disease which affects the temporal artery. It usually affects only one side, and therefore the patient will usually present as a female who is more than 55 years of age with pain on one side of the head, especially aggravated while combing the hair or while chewing. Other than that, the patient might also have a complaint of joint ache, which is usually due to polymyalgia rheumatica, PMR, and that is present only in 10 to 20% of the cases. In this slide, you are given a format about how to approach a patient who is having giant cell artery for pain. You can either use Socrates or you can use oldcaart. Oldcaart is onset, location, duration, character, aggravating, associated factors, relieving factors, and time. Or you may use Socrates, which is present on the slide here. Usually the pain is of a severity of around 4 or 5. The patient might have eye complaints whereby the patient would say that they are having decreased vision or halos. Some of the differentials are glaucoma, meningitis, migraine, stroke. In MAFTOSA, there are some of the components that are important, such as the family history, smoking, and the impact on life. In the management, check the vitals, and it is very important to conduct an eye examination using fundoscopy. In such patients, you would find that there is a rise in their ESR level and CRP, which are inflammatory markers, and a decrease in their hemoglobin. When you're explaining to the patient about the diagnosis in every case, you have to make it simplified and in patient language. This is an autoimmune disease of the temporal artery, right? So you would explain about that as inflammation of temporal artery due to the defense mechanism or the defense system of your body acting against you. How would you manage this patient? Usually they are to be sent for a temporal biopsy at the rheumatologist, and they are often started on aspirin. They will be also given steroid, and therefore you would need to give them a steroid blue card. Whenever you are giving a patient steroid, it is important to taper. Now moving on to some other forms of headache, that is tension headache, migraine, and cluster headache, which are the commonly asked headaches in multiple choice and in OSCE, because of some overlap between the three of them. As you can see in this diagram, each of them have very distinct features. We'll look at each now. So when you're looking at migraine, it is mainly due to a decrease and then followed by an increase in the blood flow, and the occurrence is twice as much in female as in male. Some patients have aura, and the aura can be visual, can be sensory. You would need to ask some questions to these patients to know a trigger factor. For instance, you can use this mnemonic to remember, that is chocolate. And there are some criteria that is used to diagnose migraine if ever it is presenting without an aura. The mainstay of treatment in migraine is analgesic and triptan. As far as the prophylaxis is concerned, propranolol and amitriptyline may be used. Coming to how the case is to be taken, you can see that the same applies. You take the socrates, you have very distinct points in this. You need to look for the exacerbating factors, which may be because of diet, water, coffee, chocolate, cheese. And there are some questions in MAFTISA that are very important to be asked, such as oral contraceptive pills. Now coming to tension headache, which is the commonest of the three headaches, it can occur up to 70% of the cases, and the ratio of male to female is equal. The patient usually presents with a bend-like constricting headache around the head, and it's similar to the word tension. Some of the causes are related to stress and lifestyle. As far as the treatment goes, it is easily treated with over-the-counter medications, stress management, relaxation, exercise, and these are lifestyle changes. They may take time to occur. So always be kind to your patient when they come to you and tell you about something that needs lifestyle changes. Such patients often feel that they are distracted because of the headache, but it is not a debilitating headache like cluster headache. If ever the patient does not get better with the medication or has trouble sleeping, you can refer them to the neurologist or the sleep specialist. But remember, if ever you're giving the PLAB 2 exam, there you will be an FY2, and as an FY2 doctor, you would need to get the registrar involved. Cluster headache, the worst and the rarest. It occurs more in male than in female, and often it is due to vasodilatation as well as activation of the trigeminal-vascular system, and this would lead to the firing of parasympathetic nerve fibers too, and that will cause autonomic symptoms such as lacrimation, rhinorrhea, and facial vasodilation. What is important to know is that this pain is so horrible that the patient might even be suicidal, which is why it has had many names given to it. It is also known as histamine headache, alarm clock headache, or suicide headache. It occurs at the same time and leads to an unbearable pain. This condition is very severe. It is often misdiagnosed. There are some trigger factors that can be noted. However, the problem with this is that there is no cure for cluster headache. There are multiple medications that have been tried with it: triptan, oxygen, ergotamine. However, it is often worse than this whole polypharmacy of medication. As prophylaxis, verapamil is the first choice in both episodic and chronic cluster headache. As far as the surgical methods are concerned, the results are quite poor. This is how a case sheet for cluster headache would look like. You would have patients that are very restless. They cannot sit in one place. They might even be banging their head on the walls. What are some take-home message and special tips? Do not skip safety netting, even if you skip the R in your daily consultation. Yeah, I'm sorry, there is a typo there. In GCA, you would have a temporal area pain with or without a visual complaint. It is autoimmune. It is treated with a steroid, and you would need to taper it off. And the rheumatologist might need to do a temporal artery biopsy, hence a referral is required. As far as the migraine is concerned, it often is accompanied by aura in 20% of the cases, and it has some trigger factors such as diet, travel, family history. The mainstay of treatment is triptan and painkiller. Propranolol and amitriptyline can be used as prophylaxis. Tension headache are very common and have patients having vague, dull pain around the head, and is usually due to hectic lifestyle. The treatment is painkiller and avoiding triggers. Cluster headache are rare and misdiagnosed. There is pain around the eyes and at the back of the eye. It is usually one-sided symptoms. So there is watering of the eyes, and also there is mental health that is deteriorating because the patient experiences excruciating pain. And most of the medications are on trial basis. Hence, lifestyle changes are a must. With that, we come to the end of today's first part of neurology. I hope you find it useful. So this is a wrap-up, and you were watching Matters That Matter. Stay tuned for part 2. We'll be releasing soon. Thank you and have a nice day.